Welcome to our Neurohumanities Network. This is our very first webinar of the year 2026, and we have a very special guest today, so we are all excited. To introduce who we are a group of neurologists, trainees, and artists who are interested in this intersection between arts, humanities, and neuroscience. We and our group is always growing. Now we are currently have 15 team members. And we also acknowledge the help and support of Arts and Humanities Initiative at Harvard Medical School. And these are few things that you can stay connected with us. We have YouTube channel where you can get the lecture archives, and we also have a lot of social medias where we posted all these like main events and share all these like and other like events. And we also have newsletters. And this is the QR code for the newsletter. And we also have our amazing website. And you can check all these things on the website as well. So today, we have an amazing guest speakers, Dr. Mei Rui. She will be talking about the art of musical healing. She is an assistant professor of neurosurgery and the founder and director of music and medicine at MD Anderson Cancer Center in Houston, Texas. She is an internationally acclaimed concert pianist and won bronze medalist of the 2025 World Piano Competitions. She is also the principal investigator of several large-scale multimodal clinical trials designed to quantitatively assess the physiological impact of music-based interventions and immersive live performances on cancer and dementia patients, healthcare providers, and professional musicians. As a pioneer in the field of music medicine and as sought-after speaker, Dr. Rui has been invited to present her innovative research and captivating performances integrating real-time EEG and brain-computer interface mapping at numerous internationally and national conferences, including the 2025 AN annual meeting. And I have met her in person for the very first time at AAN. When I heard her playing Beethoven, I was so moved by like all these incredible things she's doing. So Dr. Mei Rui, please go ahead for your incredible talk.
Thank you so much, and thank you for having me. It's a great honor, and I look forward to also for opportunities to connect individually with each one of you. If any of the either the research aspect or the wellness aspect of my presentation may resonate with what you're doing at Harvard. So a little disclaimer, I went to the competition school. I'm a Yale, both for undergrad and for grad school. And my some of my background and earlier it was in molecular biochemistry and later on into neuroscience. But most of my life I spent performing as an active concert pianist, and I still try to play as much as possible. And a lot of that experience and interact. I hope you can hear me. So I'm hearing some background. Yes, okay. So a lot of that actually helped fuel my passion for the research and also getting to directly interact with many of our patients. And as you know, a lot of the terminal, we have a lot of terminal patients that come to MD Anderson. So it's been a very impactful couple of years since I started the initiative there. And in addition to working on the patient side, we worked very hard to engage the physicians like you, and also trainees as well. And so I prepared some slides, which I'll share with you. Are the slides visible, everyone? Perfect. Okay.
Yeah.
So a little bit of the overarching aspects of music in medicine, which was founded when I interviewed there, it took about two years or so for the institution to adopt and adapt to the idea of creating this very new and relatively experimental initiative, which has both a very integral research aspect as well as these in-hospital live concerts, which are truly world-class. So we had over a dozen Grammy-winning ensembles and artists that have come through, and I've organized over 50 in-hospital performances, and I perform often in many of them and collaborate with many of both local and international and nationally renowned artists that come to contribute their talent and the art of musical healing with our patient providers and caregivers. So the five primary aspects of this initiative include, so we have our very multimodal and multidisciplinary clinical trials and research studies, and I will highlight a few of them and during the presentation today. And additionally, I mentioned we had over 50 in-hospital performances, mostly chamber concerts. We had a few orchestral concerts as well. And a lot of these concerts, we integrate not just the like brain mapping, which actually the audience really enjoy. It highlights the different type of music's impact on brain activation. We're actually able to visualize through, especially the new 3D one we developed. It's a real time, not a synchronized brain-computer interface mapping that allows us to look at both brain frequency changes and also the regional shifts from, for example, when we perform more lyrical versus more activating or virtuosic music and or novel music versus familiar music. Because a lot of these neural activation, the patterns are actually predictable from our last 14 months or so of data collections. And additionally, we're developing more intimate or smaller scale bedside music interventions with this is much more controlled because we go into these patient units. So think more of a solo cello or a harp rather than these more elaborate productions that we have in the public spaces. We also have more casual pop-up performances with jazz and vocalists and percussionists in the high flow public areas in the hospital during lunch hours, for example. And we also work with, for example, diagnostic imaging or the proton therapy center or chemotherapy areas to implement and distribute evidence-based music playlists because the data have shown that sometimes if we let the patient, well, preference is very important. Some music can carry side effects, especially if we're talking about physiological stress. So imagine if the patient was doing infusion and the goal is to keep their blood pressure stable, or if it was intraoperative setting where the need for sedatives could be impacted by acoustic stimuli. It's very important to be mindful of the acoustic ambiance, the acoustic environment that we're presenting each patient with. And here are a few of our studies and trials that I'm leading at MD Anderson. I want to really emphasize how important it is to gather a very multidisciplinary team of experts from different areas. So if you're familiar with music therapy, and there's actually quite a distinction even NIH made between music therapy and music medicine. So in more simplistic terms, music medicine is more quantitative and is more research oriented. So we're testing an isolated musical stimuli as a drug essentially with potential side effects and being very mindful of dosage and controlling for lots of other variables. While music therapy traditionally, over the last 2-3 decades, have been more implemented as a clinical bedside clinical service. So the trials we're developing, they're very quantitative, even though most of them they have a qualitative psycho-emotional aspect as well. So every trial has at least one, for example, neuropsychologist or psychologist on the protocol. And additionally, several of these studies, we have surgeons, we have anesthesiologists, specifically, for example, for one of the larger trials. where we are assessing, for example, the need for sedatives and pain medications in awake craniotomy patients that are having brain surgery at MD Anderson. So of course, we have musical experts, both on the performance side that record the music for each of the studies, and also the musicologists in more on the theoretical side when we're constructing a reproducible and a scalable framework and a strong rationale for why we select the music. So it's not just based on preference or on more superficial variables like just tempo or dynamic range. We're looking a lot deeper. And in the next few years, the goal is to integrate more AI and to train larger language models to be able to prescribe music more precisely based on the desired clinical outcome. So here we have the Music Star trial that's in 132 neurosurgical patients. We're measuring pre-post. So it's a 30-minute session. The reason 30-minute was chosen is that's the maximum that's feasible for these patients that are about to have a potentially very lengthy brain surgery. So if their first cases, they need to actually get there before 5 a.m. So sometimes these patients, when they sign up for the trial, we start the intervention at between 3:30 and 4 a.m. So, and then it's a 30-minute intervention. We're measuring pre-post changes in serum plasma level, stress biomarkers, cytokines. And I'm happy to report that we're seeing very promising data from the first 40 or so patients. We're seeing effect size of about 30% in physiological stress reduction that include serum level cortisol and ACTH, and also some of the neurotransmitters like glutamate and a couple of inflammatory markers. So we're going to do a deeper dive when we have a larger cohort. And the second study that is more public facing is called Your Bring On Music. So that's a more fun study. It's a collaboration with our University of Houston. We have done a lot of data collections during public performances and immersive performance as well as in hospital performances. And it's not a trial because it's hard. It's not really a randomized control trial because let's imagine these public performances, they have more variables, confounding variables that may make the study results a bit less reproducible. But the merit and the rigor from this particular study comes from the real world applications, and there hasn't been anything done like this. So for this, we are using wireless EEG to capture data on a few of the outcomes, including interbrain synchrony between a pair of musicians or between a musician and audience member. We're also looking at region-specific brain activation from, let's say, compared, Beatles to Beethoven to Rachmaninoff, and it's very fun and it's very meaningful for me also as a musician. So a lot of these artists have come through and participated in this study. And then we are developing a new study looking at the impact of prescribed music intervention on chemo brain, cognitive impairment, and cancer-related fatigue. And also we have one of my graduate students there, they're doing some animal model studies as well to look at tumor progression, longevity, survival, and in depressive behaviors in mice. And then finally, the SOS study is acronym for surgeon occupational stress. So for this unique pilot study, we have two cohorts actually. We have professional musicians that come to perform at the hospital, and we have surgeons. So we're trying to look at before, during, and after either a live concert or a live operation. We're tracking changes in salivary cortisol when they are performing something that's potentially acutely stressful. And we're looking at difference, for example, when between attending versus a novice. And we're also using more validated psychological surveys and EEG to track brain activation and to look at outcomes such as symptoms of burnout potentially. So this is more on the wellness side. Here are a few examples of our concerts we had in fall. So we have really incredible artists that come through. A lot of them are my long-term collaborators or friends. So the programming is more open and more dynamic in in these public settings compared to for the clinical trials where we really control for everything, and the music has a much more stringent selection guideline. So for example, the public concert, we program the Ravel Concerto, or we're programming the Schubert Trot Quintet at the end of this month, if you are classical music buff. But for the trials, we have a much more limited repertoire. And here is an excerpt from when the pianist and my mentor, Emanuel Ax, came to perform an all Beethoven program. You can see their patients and patients and caregivers. Some of them may come with their IV poles, and some physicians, this is at the end of a very long workday, so it's really helps with uplifting and rejuvenating after. And we have a lot of, this is another example where the concertmaster of the Houston Symphony, in Shin Song, came. So we were both wearing, in this case, this is not a dry electrode, this is a wet electrode, a more traditional EEG head cap. And we were capturing data interbrain synchrony. And later on, I'll show you a manuscript which is submitted on professional musicians and audience members. Oops. So these concerts I mentioned, the programming is much more dynamic because the assumption is that patients that do come through and attend these, they're physiologically in a very stable state. So they wouldn't be negatively impacted by music that may be too stimulating, as for example, an intraoperative setting, or for someone that's getting an fMRI scan. And here's another example from a performance with Mark Kaplan, and a very eminent violinist. And we were doing data collection on 4 participants, 2 audience members, and 2 musicians. So I've prepared, this is a very short video. It gives a glimpse of some of the aspects of my work as well, and our team. So I'm an assistant professor in neurosurgery, and I spearhead the music medicine initiative. My research focuses on understanding and assessing the neurophysiological mechanisms impacted by different compositional elements in music. We're developing an innovative clinical trial to investigate how music may help mitigate intraoperative stress and reduce the need for sedatives and pain medications in awake craniotomy patients.
Today's data could help doctors prescribe specific types of music to stimulate specific parts of the brain that might reduce, even replace narcotics and opioids for surgery patients.
You've been called a pioneer in music medicine. So when you started this research journey...
Sorry, we don't need, let me just skip through that. Okay, moving forward with some of the experimental tools we utilize for our trials include we use a lot of neuroimaging, and mostly now it's 3T. And we did 7 Tesla fMRI for a study on acute care surgeons. But and then moving on, I mentioned for the Music Star clinical trial, we running both broad spectrum proteomics as well as metabolomics. So metabolomics turned out to be a bit more practical for this particular trial because the music intervention is only 30-minute long. So some of these molecular changes may not be quite captured with proteomics, but we're seeing very, very good results with the metabolomics. And additionally, actigraphy, where we did one sleep study, and also we do another one in the dementia cohort, where we use wearables to track changes, music-induced changes in different modalities, and pupillometry. So where we measure the pupil dilation constriction from acoustic impact. And of course, vital sign collection is very essential. We've tried to monitor changes before, during, and after the music intervention, and looking at their age and heart rate. And so now we're looking at skin temperature, for example, and HRV is very critical. And EEG, I'll go a lot deeper into that when I show you the Bring Out Music study and validated surveys such as profile mood states or STI. So this is one of the earliest pilot experiments we did, where we had a lot of the music therapy literature shows that preference is a big thing, is a very big important factor in choosing the music for patients specifically. But our hypothesis was that there's something intrinsic, rather than labeling the music based on genre, based on preference, or even based on composer or songwriter. It's more important to decipher and to label the music based on these compositional elements, these more qualitative elements that are inherent to each piece. So in this example, we compared, rather than between Bach and Rachmaninoff, we actually compare in the same piece by Bach, which was a Goldberg variation, versus the same concerto by Rachmaninoff. We are actually seeing a lot more similarities between the Bach and between the melodic sections in the Bach and the melodic section in the Rachmaninoff, and rather than within the same piece for the composer themselves. So this highlights the importance of not selecting music based on genre or based on songwriter or on composer alone. So we need to do a really deep dive into each of the pieces is selected for the trial. And we've tried to test a lot of different algorithms, for example, also different platforms like Spotify, Pandora. Spotify is a lot better than Pandora. But even with that, they tend to average for example, if you like relaxing music, so they're not able to pick up. Let's say you have a 2.5 minute long nocturne by Frédéric Chopin. So this is more critical in the classical piece than, let's say, Taylor Swift or a Bob Marley song, which is a bit more uniform in that regard. But in a lot of the classical pieces, we may have an eruptive climax in 5% of the composition. And the other 95% will be perfectly suitable to be used for inducing relaxation in the clinical setting. But platforms like Spotify are so far not able to pick up these acute changes. So we record, that's the reason we record for all of our trials, and we optimize, adapt for these dynamic range and for modulations, even for things like accentuation, articulation. For example, we will remove accents if a piece is mostly a very expressive piece and a very lyrical piece, but it may have some accents or a lot of staccatos, like jumpy notes. So we manually remove them when we record. Or think of the Bach cello suites. They're beautiful, and most of it is they're very suitable for ambient relaxation. But we actually have the musicians record to remove what we have tested in earlier trials in healthy participants to be not as relaxing in terms of the participant rated scale. And I want to share a glimpse of the Music Star trial I mentioned earlier. So a very multidisciplinary team. And we have surgeons, anesthesiologists, psychologists, proteomics experts, professional musicians. Also, we have a visual art therapist as well, and composer. Here's a wonderful team that supports this study. This is a pre-op team. So I mentioned earlier, for the music intervention to happen, there's a very critical window. So we have to work on the practical side. We have to work with the flow of the care team so that it doesn't disrupt, it doesn't delay the operation. This is the room for the pre-op part of the study. You can see where it's a 3-arm randomized design, and the patients are randomized to either recorded music, simulated live music, and control, so no music. So this is the very first trial to differentiate and to assess the potential differences between the impact of immersive live acoustics versus using recorded music. So the live music is distributed by a Steinway stereo, and so our team have recorded prior on the piano. It's like a ghost piano, right? So in the Q&A, I would love to hear your input. So this, of course, removes the need to have a live musician go into the room and perform 132 times. So that's much less feasible, and also it's much less scalable and reproducible. So that's the reason for utilizing a very sophisticated player piano. It's the only instrument that really truly emulates the acoustics of a live performance. So we're not compromising the impact of the music for that regard, while preserving the integrity of the live acoustics. So as you can imagine, there was a lot to navigate having a piano, and now we're putting one. The next phase is in the OR. So that's been very complicated with infection control, but we are looking forward to starting that second phase. Check the time. Okay. We have to go a little bit faster. So a few going back a little bit to the rationales for using predominantly classical music. Even though we do program the public concerts, we have a mariachi band, we have jazz concert coming up, and we have the Houston Grand Opera. And so we have more different types of music. But for these trials, we select predominantly instrumental classical music because in the literature, specifically in the music medicine literature, it's really the only genre that's consistently proven to be not just effective, but also more, they're safer, and hasn't been shown to carry any side effects. So the side effects I'm talking about, they may include, even in intraoperative settings where the patients are under general anesthesia. There was a single study, and that's why we're hoping to do more, but a single study intraoperatively that showed that when the surgeon is playing overly stimulating or activating music, the patients, even when they're under GA, they may respond physiologically with increased heart rate and increased need for blood pressure medications. And it may also compromise their hemodynamic stability and increase respiratory rate. So it could really potentially have negative effects that a lot of the care team, the OR team, may not be aware of. So that could be that's a potential safety, significant safety issue, the acoustic environment. And now this slide is on why we are introducing so much live music into the hospital. And it's so a few of the studies have shown that live music are more impactful, mitigating both psychological and physiological stress and improving emotional well-being. And of course, and on the engagement side, live music is very different. So imagine when we walk into a restaurant, and when you just enter, you could tell if it's a live band playing versus ambient speakers. So live music has been shown to alter and affect our physiological physiology and also our brain connectivity as well through some of the neuroimaging studies differently. But there is a time and place for, in some situations, live music may be preferred, but in some situations, recorded music may be just as impactful or more feasible and easier to implement, and also cheaper to implement as well. So I'm showing this clip, and this was a patient I have performed. This was right after the pandemic, an ICU patient, and he's a car sales mechanic. And the first time he heard, I never listened to classical music. I don't know this, he'd never ever been to a concert, and but here you can see he was very, very engaged and started conducting me. So on the direct patient side, we really see a lot of visceral changes from the impact of the music, even in those that profess, a dislike or, a kind of a neutral reaction to classical music. So there's something very intrinsically and emotionally engaging, and if we select the right music, and it's really not genre dependent as many have thought. And this one is also important. Is classical music elitist? Does it depend on a prior background in understand the music theory? If we don't know what a dominant chord is, can the caregiver, the patient still benefit from the stress reducing aspect of Mozart, for example? And the answer is yes, because there was actually a large study done at Mass General. So it showed that in almost 170 waiting room patients in the waiting room and caregivers, there was a negative correlation. And so there was inverse correlation between the degree of education and the self-reported impact of anxiety reduction. So that's our studies, we also collect a lot of demographic data to look at potential associations in gender, for example, and culturally also relevant variables as well, because we have a lot of international patients. I'm not an ethnomusicologist, but I do collaborate with someone, a music therapist from Germany who is. So it's important to also to look at these other variables and factors as well. But this was one of the studies to debunk that you really have to have an appreciation, understanding of the structure or the theoretical framework for a piece of music to benefit from the anxiety or stress reduction aspect. And also that it's important to distinguish between music appreciation versus participation as well. And another really wealth of data out there. I haven't updated the slide in a year. There have been a lot more publications that have come out, things even in the last year, the anxiolytic aspect. So on the physiological stress reducing impact of especially classical music in critical care cohorts and also in pediatric cohorts. This was a seminal study done by my very first mentor, and he was actually at Harvard Medical School. His name is Dr. Claudius Conrad, and I joined his lab about maybe 8 years ago as a research scientist before I moved to Methodist to become faculty, and then now I'm back at MD Anderson. But he published this, which really illuminated the field, outlined the mechanistic aspect of music-induced stress reduction. You can see truly how quantitative it is, especially the reduction in IL-6, interleukin-6 was very significant. And this was done in a small group of critically ill post-operative ICU patients from 1 hour of exposure to slow movements of Mozart piano sonatas. So Mozart is not just for babies, not just for spatial reasoning, but also for profound physiological relaxation. And this is preliminary data we got last month from the Music Star trial at MD Anderson. I mentioned earlier, we're seeing about a 30% effect size in not salivary cortisol, in serum level cortisol, and also in a few of the other cytokines, inflammatory markers. So for an additional aspect is we look at the impact of music on surgeons. Sorry, I skipped this slide. On surgeons, not just on the patients, but when the physicians and all the nurses are operating, and how would ambient noise or how would music affect, for example, their communication, and how would the preference of an anesthesiologist versus preference of a nurse, and kind of balancing everything, how that may help improve the dynamics and the communication in the operating room. So we are, for the Music Star trial, the intraoperative phase, we're having the physicians wear something called a hexoskin shirt that measures intraoperatively changes in physiological variables from HRV to respiratory rate, heart rate, blood pressure, to really see if whether we're letting them choose self-selected music versus prescribed music versus silence, how that may impact their physiological stress. Others have already looked at the data, both in trainees and in attendings, the precision and precision accuracy and also speed of surgeon performance, laparoscopic performance, and as well as on surgical simulators. So here are some of the papers, and I'm happy to share the slides too. It's very interesting to see the acoustics could affect not just the first time, but also the learning curve when they are repeating the same surgical tasks. Classical music has been shown to promote the learning curve versus other type of music. And also familiar music or self-selected music tend to more activate their motor areas. That was shown by one of our studies, where we compared the surgeon-selected music versus prescribed music. So when they like the music, there may be microscopic movements, or not so microscopic movements, even when the music doesn't have a strong pulse. So if you're doing a microsurgery, that could potentially impact, or may induce small movements that the surgeon may not be consciously aware of. So it's important to decipher what these acoustic stimuli may do to not just us physiologically, emotionally, but also to surgical performance in the operating room. So this is a slide I hinted at a little bit earlier, that music can carry dangerous side effects, including potentially inducing arrhythmias and hemodynamic and respiratory instabilities in patients that may be under sedation or general anesthesia. So here are a few of the variables where we should be looking out for. Vocal music. Vocal music may have, the vocal music, emotionally charged music may be interlinked. So anything with lyrics, words that may have a strong emotional association. Think of a patient on the table. They hear a song by Lady Gaga, or a sentimental song that was their wedding song, and that could be, and they just had gone through a divorce, so that could be something very stressful. So, and that could increase, that's been shown to increase their heart rate and potentially need for sedatives as well. So I see a raised hand.
And we can also take questions at
Yes,
the end.
of
We'll have a
course, yeah.
Q&A, but I love that
Okay.
people already have questions. That's great.
Okay, great. So I'll skip to the end. Just I'll spend 1 minute on your Bring On Music, so you can see a glimpse of our data collections. So this is from a live brain mapping session. This was a more community outreach concert we did at the Asia Society, where we performed the Beethoven Archduke Trio, and we had 2 audience members. One of them you can see. So we're mapping his brain in reaction to the music. And this was a 2D version of the mapping. We're also tracking, you can see the ECG on top. So we're looking at cardiovascular changes as well. It's very unique and interesting and engaging for the audience to see the live data. And we also collect data on a lot of our physicians as well during the performances, and professional musicians. So this was an in-hospital performance where Robin is a Grammy-winning violinist, and we have a Dvorak piece here. We're looking at synchronously data collection on 5 participants, 3 musicians, and 2 audience members. So here we're looking at interbrain synchrony between 2 pianists, and so using the piece where the original Mozart effect Nature paper was based on 488, and comparing it to a more activating piece, emotionally activating piece by Sergei Rachmaninoff. So we're seeing some, very beautiful data with the EEG data on the cognition side, and also with gamma and on the relaxation side, and we look at flow state as well. So I think we'll take Q&A, and let me skip to the end. So this was a manuscript we submitted to Nature Scientific Data on the first year of our collections. Sorry, let me skip to the end. Okay, so and I want to thank our we have a wonderful team, have some wonderful trainees who are PhD medical students, different institutions. A couple of them are actually working remotely as well. So if you have any students that might be interested in learning more about the initiative, and or maybe if they're in the summer, if they want to work on any projects, if you're interested in reaching out to discuss any potential collaborations, please let me know. Thank you.
Dr. Mei, thank you so much for this talk. This was truly, outstanding. I know that a lot of people have a lot of questions, and so I think we're just going to go and start. I know that I saw some questions pop up in the chat, sorry. So I think Dr. Zarin was mentioning, since we know Mozart piano sonatas K448 and K545 are helpful in treating refractory epileptiform seizures in humans, is there any research forced on Mozart's music for other medical conditions?
So this question might have been before I showed the slide on ICU patients. Yes, that's something we're doing at MD Anderson as well, more on and because the seizures and epileptic that's being very well established both in pediatric and in adult cohorts. So it has nothing to do with the kind of the comprehension for the theoretical aspect. You don't need any training. Babies can benefit tremendously from that type of music as well. And there's one study that even compared to using a mother's soothing voice, and I think Mozart might have won for that study in babies. So yes, so we are for two of our trials, we're not just using Mozart, because if you go back to the root, the researchers selected those pieces not because they were compositionally superior to a lot of the other works. So there's really a wealth of a huge library of pieces that could be harnessed for our research. But that's why we engage all the composers and professional musicians for the study teams. And sometimes we may compose music right now with AI, even though most musicians are not a fan yet of AI generated, especially classical music. It's very painful after the first couple of minutes. But there's a lot of potential for what the may hold. But yes, so it's been studied very often now and I'm happy to send some references in ICU, more in critical care settings. But now we're doing a lot in cancer, pain, mood modulation, but not just using Mozart, but harnessing these beneficial variables, these intrinsic properties. That's what made the Mozart 448 therapeutic. So we're harnessing these variables and we are trying to adapt, or we're trying to select other type of music and record other pieces that may just be as or even more effective. For example, the Rachmaninoff concert I showed with the two piano, and I just skip over. We do have the whole performance on YouTube. I'm happy to share later. But we're actually seeing for the relaxation side in alpha brainwaves, which is associated with deep relaxation, the slow movement of the Rachmaninoff was even more effective at modulating, kind of and training the brain to go into alpha state. So sometimes the flexibilities in tempo we found, if you compare a very strict, a Baroque piece with very strict rhythm with something that's a little more dynamic, the tempo. I'm not talking about dynamic as in volume, right? But I'm talking about dynamic as in the natural rubato, the flexibilities in the rhythm in the music. The one with the more flexible rhythmic structure is more impactful and more effective at modulating stress. And my hypothesis is that it kind of works similarly as HRV, right? So HRV is a critical indicator of our well-being, wellness. So HRV is the higher the volume, so the more slight variations you have between heartbeats, actually the healthier we are. So in a way that when the music is more flexible or more human, it may align with the perception, with our perception, or the therapeutic impact may be more profound. So that's another argument against using computer-generated music, because you can give it a tempo, right? You can't really program where to stretch or where to be flexible. So that only comes from a human conducted performance. And the live is even better. Then you can really integrate the breathing and then the energy from the room.
Amazing. And I think there's another question that was asking if there's any work on use of music and clinical hypnosis together.
I have to clarify that the hypnosis is not my area, but if I'm very interested in learning more. And I have a colleague, classmate from Yale. He's a psychiatrist, but a musician at he's at Harvard now, but he does hypnosis. So I've been thinking of collaborating with him for a while. I'm sorry that I'm not able to provide more background specifically in hypnosis, but yes, especially with all the ketamine, I've been approached several times with physicians that conduct ketamine-based research with induction, how that may help. So while I'm not familiar with hypnosis, I do know from the anesthesiology side, if you use the right kind of music, it may help reduce the need for sedatives. So for the need for propofol, for example, to put somebody to sleep. So if they're more relaxed, they're more likely to go to sleep, and so you don't need as much pharmaceutical intervention, which is good.
Perfect. And then let me see, is there anyone else who'd love to ask a question? And feel free to unmute yourself. I don't see any hands.
Yeah, could I ask a question?
Oh, yes, please go ahead.
Hi, yeah. So I know you talk more about the therapeutic effects of music. I know a while ago, and often parents say, their kid can be listening to music while learning or doing classwork. I saw a Huberman podcast once about, how listening to pop music and versus, specific frequency hertz music may not be as beneficial to kids learning while listening to music. But it's interesting hearing about people doing surgeries while listening to music. And I thought, is there a difference in our brains while we're listening to music when we're learning / when we're doing repetitive tasks? Is music beneficial to one domain over the other?
That is an excellent question, and that's really, really very relevant to our work. And I think a lot of you may be curious about that as well. So on the studying aspect, right, you mentioned some music has been shown to more effectively promote, for example, flow state. And that's something we are trying to capture. Usually flow state is manifested with our EEG data, with the synchronization of theta and desynchronization of gamma. So when we see that coupling, it means the brain is in training to go into flow state. So actually, slow Mozart has been shown to be really great at in training the brain to flow state up after about only 90 seconds to about, sometimes it's even shorter. And for you mentioned repetitive tasks. So I guess it matters a lot if you're doing something that's cognitively demanding, in which case you really want to minimize novel music, because novel music tend to engage a lot of our frontal regions with, where we execute critical judgment. So we're judging the music, and that's cognitively demanding. So that would take away from the task at hand that you're trying to do. So I would avoid novel music. I'll avoid music with a very activating pulse, because again, that engage a lot. Something with very activating pulse, unless, again, going back to what you said about the mundane task versus something more demanding. The mundane task may be okay, but something that's more difficult and that will require more of your cognitive reserve will be too distracting. But going back to the surgeon side, yes, that's definitely, I was talking to an ophthalmology physician as well in this because they do so many microsurgeries, and I was discussing this with my colleague who was a plastic surgeon as well, especially for microsurgeries where the surgeon may be more prone to small tremors, right? Any small movements may jeopardize or compromise the quality of when they're making we're doing a resection of a brain tumor, or whether working on the eye. And, I would imagine it's less critical for an orthopedic surgeon because if something is not on a microscopic scale, it might be a little less dangerous. But if they're listening to death metal, it could absolutely have and it's been shown to could potentially have a negative impact, not just on the patient, but on the surgeon, even if they love the music, because it could also affect the rest of the team, right? The OR team. So I do know surgeons, no, two cardiovascular surgeons, they listen to very, very active music and very big, very loud hip hop or death metal. These could really be not safe in the OR setting. But I have some playlists I'm happy to share as well if anybody's curious in looking at the music we use for our trials, our studies.
Oh, that would be amazing. I think we would, I personally would love to see at least what's on the playlist, and we'd love to feature it also on our blog. So that would be like a fantastic addition. I think we have one more question. Sherry's asking, are there any recent results about patients' post-surgical recovery when music is played during surgery?
Yes. So that's more longitudinally. Is this a specific cohort of patients, or in general, any type of surgery? Is it more inpatient kind of critical cases versus like emergent cases? I think there will be a differentiation in the. So I'll assume this is maybe we can ask Sherry to clarify.
And
Sherry, are you interested in learning about a specific, hello, I guess
hi.
specific,
No, and any area that you might have insight into is fine. It's just a more general
so
question.
there are studies that have tracked how maybe length of stay. And the biggest contributor where music could have an effect is the reduction I mentioned, how it may reduce during intraoperatively the need for sedatives, right? So it may reduce deliriums when it may reduce the time they'll spend in the ICU, and versus or in stroke, this was done more often, and especially during the recovery window, exposing the brain to music. And in this case, the patient preferred music is like exercising the brain without inducing forcing them to do something that's too exerting. So before the patient may be willing or able to do any physical therapy, right? Let's say you're recovering from a brain surgery, they could benefit from a small infusion of healthy blood flow within the brain, because music is so global. There's nothing quite like music inducing an oxygenated blood flow. It's very global, especially if you mix what I mentioned, novel music, music with lyrics versus instrumental music. If you mix different types, you really get every region, even the occipital region. Even with your eyes closed, the occipital region could be very activated in the imagery, especially if you have an emotional association with the music. So that's something we do during the live brain mapping. I've recruited participants, and then from their brain reaction, we're able to predict their association or the relationship to the music during a live setting. So that was very, very neat. We did that for neuro karaoke, where we selected people really random, just like you, if this was a live session from the crowd, and they'll tell us what song to play, right? And then from the ring reaction, we were able to accurately, in all 5 of the participants, that during that hour predict how the music was familiar, whether the music had a strong emotional association or not, or if the music was on a valence scale, how much they liked the music. So we try to get a variety. So that was really neat. But
And then I think, Lisa, did you have your hand raised. I apologize if I missed you earlier.
No, but I just wanted to say thank you, Mei. This is really exciting. I'm curious, what you have such an expansive list of researches. What's exciting you the most right now?
Oh, that's a good question. I'm very thinking. So, and that's right. You mentioned that it's very, very multimodal, right? Our studies are very multimodal. I was very excited about the metabolomics, proteomics data. We were anticipating a 15% most effect size. That's when we did the sample size calculation. So it was very beautiful to see. So I would definitely want to dive deeper in that. But as a musician, of course, more on the both on the brain and the heart side. I want to get more live HRV data on both the musicians and the audience members. That's on more on healthy participants as well. So the challenge with conducting all these studies, we need to have for IRB to approve, right? So for even for selecting the music, so we had to validate a lot of even the music selection in healthy participants first to show that it worked. So now we're past that stage, we could do a lot more. And with the live EEG, that's very educational, and we could do a lot of community outreach projects with the brain computer interface mapping. I didn't get to show the 3D design, but it's I'm very excited. Maybe if I'm happy to share a clip, an email to if you want to reach out. My email is mrui@mdanderson.org as well. But just excited about collaboration. There are a lot of possibilities, and I think that a lot of the previous studies, they are too siloed in a way. People either didn't have enough musical experts, or it's it's not quantitative enough. So now we're very excited about getting a wealth of more quantitative data on the brain and on physiology.
Amazing. Thank you so much. This was truly an outstanding talk. I think it's time. Fortunately, it's 9 p.m. So shortly after 9 p.m. So I think that's going to be the last of the questions. And I'll just hand it over to Galina.
I want to add my thanks, Mei. This was really fascinating. I am sad it's 9 p.m. because I have about like 6 questions I want to ask you. So looking forward to more conversations. And if you enjoyed today, please join us for our next seminar. Our next talk in February will be with Asher Ali and talking about Alice in Wonderland syndrome and migraines. So hopefully you can join us there. If you enjoyed what you saw today, please leave us some feedback on our survey that you'll get at the end. And we also have some upcoming booster sessions. The next one will be announcing, still hasn't been in our newsletter, so you're heard it here first, because we're going to have a tea tasting in March. So join us for a live virtual tea tasting where we're going to talk about the tantalizing aspects of taste. So hope to see you there, and thank you for joining us tonight.
Cool.
Have a good night, everyone. Thanks so much, Mei.
Thank you for organizing this.
Thank you.